Dr. Craig Hall. I'm here today to talk to you about bladder cancer. Bladder cancer is the fourth most common cancer among men and sixth most common cancer among women. Interestingly, you don't hear a lot about bladder cancer, although it's obviously not a rare cancer. In fact, in the United States, more than 50,000 patients will be diagnosed newly with bladder cancer this year. And importantly, because a lot of patients live many years with a diagnosis of bladder cancer, there's estimated to be over 500,000 patients in the United States who have had a diagnosis of bladder cancer in the past. Bladder cancer develops as a result of chemical exposures. There are a number of cancer-causing agents that are either ingested or present in the environment that are associated with the development of bladder cancer. In the United States, the most common risk factor for the development of bladder cancer is a prior history of smoking. In fact, approximately 2/3 of patients who are diagnosed with bladder cancer have a strong history of tobacco smoking. Secondly, some patients, most commonly because of their occupation, are exposed to cancer-causing chemicals that can induce bladder cancer. Finally, because not all patients who smoke ultimately get bladder cancer, there is a strong genetic susceptibility component that is associated with ultimately bladder cancer development. The most common symptoms associated with bladder cancer are blood in the urine, as well as issues with urination. Blood in the urine may either be microscopic, in which case it's not visible to the patient, it's only found on a urinalysis test, or at times it can be significant enough that it's visible to the naked eye. Urination symptoms that are commonly associated with bladder cancer are what we call irritative type symptoms that typically are frequent urination, urgency with urination, or pain with urination. Presence of blood in the urine or these symptoms with urination warrant further evaluation for bladder cancer. The diagnosis of bladder cancer ultimately involves visually inspecting the bladder and taking a biopsy for tissue examination. The lining of the urinary tract, however, from the bladder all the way up through the kidneys is a continuous lining we call the urothelium. Patients who have blood in the urine, because the source is not obvious at the beginning, warrant a full evaluation of the entire urinary tract. This typically involves imaging studies to assess the kidneys and the tubes that drain the kidneys down to the bladder called the ureters, and an endoscopic examination of the bladder, which is termed cystoscopy. Most commonly, a CT scan is obtained to evaluate the status of the kidneys and ureters. The initial cystoscopic evaluation is typically done in the urologist's office using a flexible scope under local anesthesia. If an abnormality is identified that is a cause for concern of bladder cancer, the patient is then scheduled to have a more detailed examination done in the hospital setting under anesthesia. This procedure is typically called a transurethral resection, meaning that the scope is placed pre-urethra, there are no incisions made, but the urologist is able to place a scope through the urethra into the bladder and actually biopsy and scrape the tumor from the bladder. This specimen is then retrieved and carefully analyzed under the microscope to determine the particular type of bladder cancer and make plans for further management. There are two main categories of bladder cancer. This has to do with what we call the grade of the cancer, which is basically what the cancer looks like under the microscope. This gives us a lot of information in terms of the behavior and seriousness of a given patient's tumor problem. The majority of patients, at least 2/3 of patients newly diagnosed with bladder cancer, have what we call low-grade bladder cancer. These are cancers that rarely invade into the tissue of the bladder itself, but grow into the interior of the bladder, oftentimes looking like cauliflower growing within the bladder itself. These tumors are rarely, if ever, a threat to a patient's life, because without the ability to invade into the tissue, it doesn't have access to the bloodstream where it can then spread and ultimately cause problems. The other group of patients, approximately 1/3, who are newly diagnosed with bladder cancer, have high-grade disease. These patients have a potentially life-threatening bladder cancer from the get-go and typically warrant much more aggressive treatments. The ultimate treatment, however, depends on further characterizing the tumor, and this is what we call the stage of the cancer. The stage of the cancer really means what is the extent of the disease. The staging of bladder cancer really has to do with how invasive or how deeply the cancer invades or spreads. Patients that have CIS, or carcinoma in situ of the bladder, have a cancer problem that involves highly malignant, high-grade cells. However, they're only confined to the surface of the bladder. Patients that have TA bladder cancer are patients that have a tumor that is growing on the surface of the bladder but does not penetrate. And patients that have T1 and T2 cancer have cancers that do in fact invade into the wall but don't penetrate beyond the wall of the bladder. Patients with T3 bladder cancer and T4 bladder cancer means they have cancers that have actually penetrated beyond the bladder. The other important factor in invasive bladder cancers is the status of the regional lymph nodes and whether there's any spread to those areas. That influences treatment options as well as affects the prognosis greatly as well. Really, the most important part of managing patients with low-grade non-invasive bladder cancer is putting them on a strict regimen of surveillance to monitor the bladder, to detect recurrences early so they can be easily taken care of. Some patients who have low-grade non-invasive disease, even though it's not a life-threatening situation, will have multiple recurrences that are quite a nuisance problem. And some of these patients may require more aggressive treatment with a form of chemotherapy that is placed into the bladder to try to prevent recurrences from developing. Patients who are found to have high-grade bladder cancer, that is either in the form of carcinoma in situ, non-invasive tumors, or tumors that have just invaded the very surface of the bladder, need more aggressive treatment. The reason for this is because without further treatment beyond the initial scraping of the tumor, these patients over time have a high risk of the cancer not only recurring, but progressing to a more invasive problem that has a chance to spread and cause significant problems and even death. So for these patients that have high-grade disease, after the initial scraping, the recommended treatment is immunotherapy or chemotherapy that is placed within the bladder following the resection of the tumor. The most common and effective treatment in this setting is the use of BCG. This is a type of immunotherapy that works through the patient's own immune system. It is administered intravesically, means that it is placed into the bladder. And simply, the way it works is that a patient will come to the office, the bladder will be drained by a catheter, and the BCG is instilled into the bladder. What this does then is we're intentionally causing a special type of bladder infection. BCG is actually a vaccine that's used in other parts of the world to prevent TB. But when administered into the bladder, it stimulates a TB type of infection within the bladder. This infection then stimulates the patient's body's own immune-fighting cells, disease-fighting cells, to come to the bladder. In the process, they eliminate the BCG over time, but they also recognize cancer cells and can eliminate them from the bladder as well. And this has proved to be a quite effective treatment for bladder cancer, especially for patients that have high-grade disease that has a chance for progressing to more invasive and even metastatic disease. Occasionally, some patients are not suitable for BCG because of other illnesses that typically involve their immune system. In these patients, even though it may be less effective, chemotherapy placed into the bladder may be used with the same rationale to try to prevent these cancers from recurring down the road. Patients who are found to have high-grade bladder cancer that is more invasive, that is, invading into the muscle wall itself of the bladder or even beyond, have a very potentially life-threatening situation. These patients require aggressive therapy. Following further staging studies, which are performed to make sure that the cancer has not spread widely throughout the body, these patients are typically treated with aggressive surgery to remove the bladder and the surrounding lymph nodes. In the majority of these patients, surgery oftentimes by itself is inadequate, and chemotherapy is recommended to consider for most of these patients, either administered before the surgery or after, to increase the chance of cure. This brings up an important point in the management of patients who have invasive bladder cancers. That is, these patients are best treated with a multidisciplinary approach. The best outcomes are typically obtained when a team of physicians involving surgeons, medical oncologists who administer chemotherapy, and even radiation therapists can work together to determine the best treatment plan for this potentially deadly situation. Although removal of the bladder and chemotherapy oftentimes is the most common treatment for patients with invasive bladder cancer, at times because of patient preference, or also because of patients who have significant medical problems that make surgery too risky, another alternative for management is a combination of chemotherapy and radiation therapy. This is actually a common treatment used in some parts of Europe, but less commonly used in the United States. However, in properly selected patients, outcomes similar to that reported with surgical removal of the bladder can be obtained. Bladder cancer, as we've discussed, covers a great spectrum of disease ranging from the low-grade non-invasive cancers, which are typically not life-threatening, to very life-threatening, deeply invasive disease. And it's important that as patients you understand where you fit into this disease category, and it's important that you discuss with your doctor these issues. For patients with low-grade non-invasive disease, I think it is real important that you ask your physician whether or not he plans to administer chemotherapy at the time of your biopsy or transurethral resection. In addition, I think it's important to discuss the need for further treatment following the initial diagnosis of low-risk disease. For patients with invasive bladder cancer, as mentioned previously, I think it is important that you discuss treatment options not only with your urologist, but also with a medical oncologist, as the majority of patients with invasive disease will also benefit from the combination of surgery as well as chemotherapy. The diagnosis of bladder cancer can be quite daunting. Remember that Guidepost of Strength can be a valuable resource to guide you along your journey.